Hello, Dr. Amanatullah. How are you doing?
I'm great. Thanks again for having me.
Absolutely. Let's talk today about implants. What are the most popular types of implants?
Yeah, so I would say worldwide, there are really two types of implants that get put in general, and they differ for hips and knees. The two types really separate around the utilization of cement. So there are cementless implants, meaning they have a porous surface and that allows your bone, it actually tricks your bone into thinking those pores are actually bone and their bone cells grow into it and it actually incorporates into your body. The other one is cement. So cement is like you would use anything else to stick two things together. It sticks a metal piece together with your bone and it actually interdigitates inside of the bone to hold it there. So you would think that the cementless one would be the best. In fact, almost all knee replacements are cemented for lots of different reasons. Recently, we've toyed with cementless knee replacements, and actually, cementless knee replacements have a very poor track record until recently, until modern implants have been in place, and that's for numerous reasons. But when we talk about hip replacements, the vast majority of hip replacements in the world are actually cemented. And they've been cemented for a long time. In fact, the first FDA approved hip replacement, even in the US, was cemented. But because of some complications, not related to cement, but related to particle wear that can happen on the plastic side of the joint, people developed cementless joint replacements. And that is the dominant type of joint replacement used in the United States now.
When you, as the surgeon, have to decide which type of implant to give someone, how do you decide?
Yeah, so I think that patients and surgeons want to use the most latest and greatest implant to get the best result. And I think that this is different from a car or your TV because what you have to imagine is when these things are developed, they're tested, they're vetted, they're put in patients for initial trial. But what we want is a result that lasts 30 years, 50 years, decades. And there's no way to study those before they're released. They get studied kind of post market. And so you can imagine a scenario that happened recently with, say, metal on metal joint replacements, where we thought everything was great. We put them in, and it turns out the track record of those joint replacements aren't so good. And so I think our definition of what implants to pick and how we should pick them has changed. I look for the latest and greatest in the track record of the implant, unless there's a compelling reason why it's going to make my practice so much better. And so I use implants that will last for decades upon decades, that have been proven out over time to be the best implant available, and try not to gravitate to the newest, latest, greatest, hottest thing unless I think that's going to change and optimize my practice or my patients' outcomes. Even that I would use experimentally and make sure my patients knew we were using it. Because again, it's not about the result 2 or 3 years from now, like most of the FDA studies would allow us to do. It's about the result decades from now. And keeping our eye on that prize is probably more valuable than using the latest and greatest thing.
So, speaking of the latest and greatest thing, the fun, the flashy, what is the next big thing on the horizon for implant technology?
I think a lot of the implant technologies that are going to come on board are not going to focus on the bearing surface. So we've seen a lot of focus on that. People may have heard of metal on metal bearings or ceramic on ceramic bearings. I think a lot of these things are falling away with modern, highly cross-linked polyethylene, which is the plastic that we use on the joint replacements. I think a lot of the new implant technologies will focus on addressing new questions. Those questions would be like suppressing infection. What kinds of coatings, what kinds of treatments can we use to decrease infection for our patients, and how can we link those to the implants? What kind of implants will grow in faster or utilize the body's resources better? I think, and then again, I also think you'll see new technologies come on board that'll help us put the implants in better. How can we more ideally or patient customize the placement of implants and how can we be more exact and precise in their placement. So I think the implant itself will change very little, but some of the processes around the implant will help our patients. And then maybe even some of the processes around the implant will help the surgeons do an even more accurate and more precise job.
If there's one thing that you are the most excited to see coming up in terms of either the implant itself or the technology surrounding it, what would it be?
Hmm. So I think there's some things that need to be vetted. So I think recently you see the rise of robotic surgery. We had a surge in patient customized instrumentation. We had a surge in navigated joint replacements. People are toying with changing the position of components to be in a patient specific location. I think robotics remains a very interesting point of view of whether it can give us the accuracy that we want. So surgeons are just like people; they have accuracy, probably within a few degrees. The question is whether robotics can make that better. I find that exciting, and whether it being better actually makes a difference for our patients. We don't want to be expending money on robots that we don't need. So I think that's going to bear out over the next few years. I remain the most excited about technologies that are going to suppress infection. I'm very much interested in infection, and I think there are some very interesting things that will come online. And I view infection as the challenge of my generation of surgeons to solve. And I think you'll see over the next 20 years or so the emergence of implants that will actually help our patients stave off complications. I remain the most excited about that, but yet optimistic about technologies like robotics that will help us position implants better.
Well, we'll be on the lookout for your name on some papers that help to forward those causes.
No worries, for sure.
All right. Thank you so much, Dr. Amanatullah.
Thank you.